following podcast is part of a certified educational activity titled Applying Evidence to Practice in Postpartum Depression, Expert Guidance on Integrating Therapeutic Innovations and Shared Decision-Making Strategies to Optimize Patient Care, featuring Dr. Christina M. Deligianidis from Zucker Hillside Hospital at Northwell Health in New York. Access the entire activity and complete the post-test at peerview.com/HYR860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Christina Deligianidis, and I'm the Director of Women's Behavioral Health at the Zucker Hillside Hospital at Northwell Health in New York City. I'm a perinatal psychiatrist, and I'm so glad that you've joined us today for this educational activity named Applying Evidence to Practice in Postpartum Depression. So let's get started. As you know, perinatal depression is one of the most common medical complications during and after pregnancy and may arise de novo in the postpartum period or during pregnancy. Recent CDC estimates indicate that postpartum depression, or PPD, symptoms may occur in over 13% of all live births in the US. And we know that women with postpartum depression are 27 to 46 times more likely to experience postpartum depression during subsequent pregnancies. 70% of women with a pre-existing mood disorder who discontinue their antidepressant in pregnancy will experience a relapse of major depression. There are numerous risk factors for postpartum depression, and this slide outlines many of the most common ones. Some of them include depression or anxiety during pregnancy, low levels of social support, also family history of PPD, gestational diabetes, and stressful life events. So these are important factors to elicit from patients to try to identify their risk factors. We know there are many negative consequences of untreated postpartum depression. Unfortunately, untreated PPD increases the risk for many maternal behaviors. Some of those are included here. So addictive behaviors, relationship difficulties, an elevated risk for suicide, and also it changes mom's interaction with her children. And so their parenting behaviors are impacted. We see that depressed mothers are less likely to talk or engage or interact with their babies. They can use car seats less often, and sometimes will not bring in their children for routine scheduled vaccinations or well child checks. We also know that untreated PPD can increase the risk for several problems that can develop in children who've been exposed to postpartum depression. These are listed here. They can include sleep problems, slower language development, behavioral issues, and then also those children can be at increased risk for developing psychiatric issues later as children, adolescents, or adults. So a common question that I've encountered in my colleagues in OBGYN and other primary care physicians is how to best distinguish the difference between baby blues and postpartum depression. And so we've created this table to better differentiate and have a resource to help you differentiate the two. Because one, baby blues does not require clinical intervention, but postpartum depression does. And so baby blues is really common in about 85% of new mothers. It occurs pretty close after delivery, so within a few days after delivery, especially by day 4 or day 5. The duration, the symptoms can kind of come and go, but they are usually all gone by 2 weeks after delivery. That's a real defining feature. And the symptoms that women report, such as their mood changing, some tearfulness, anxiety, irritability, they're really mild and they do not impair functioning. And that's another very clear distinguishing feature from postpartum depression. Again, this resolves spontaneously, and it's not related to a woman's psychiatric history and not predictive of future issues. Now, in contrast, postpartum depression is identified or diagnosable in 13% of women. The symptoms typically emerge during third trimester of pregnancy and 2 to 3 months postpartum. The symptoms last longer than 2 weeks. The symptoms are daily, and if untreated, can last up to 3 years. This is a clinical diagnosis of major depressive disorder, and we're going to discuss that on the next slide. The functioning is impaired from the depressive symptoms. So again, really important to ask about mom's functioning at home. And this requires treatment. Postpartum depression is more common in women with a history of depression, of major depression or bipolar disorder, and it predicts future episodes as well. So here are those diagnostic criteria. The American Psychiatric Association diagnoses as major depressive disorder with peripartum onset. And this really recognizes the research that indicates that for many women, depression can begin antenatally or during pregnancy. And so these are the symptoms that I'm sure you're familiar with. 5 or more of those symptoms need to be present nearly every day during the same 2-week period and really present a change from previous functioning. Again, that functional impairment. One of the symptoms must be either depressed mood or reduction in interest or pleasure. And you can see the remainder of those, including change in weight or appetite. Now, yes, postpartum women are having changes in their weight, but their appetite is severely, usually depressed. Women need reminders to eat, especially nursing women struggle to eat or stay hydrated to produce breast milk. We see really severe insomnia affecting their ability to fall asleep, stay asleep, or wake up at the right time. And that's outside of the normal perturbations of feeding Q2 hours for breastfeeding. We often see more of agitation or irritability than psychomotor retardation, but it can vary. The fatigue is very different than the fatigue we see in a healthy postpartum woman who obviously has sleep impaired by caring for their newborn. And then we see feelings of worthlessness or inappropriate guilt, difficulty with concentration, and we can have women who report suicidal ideation as well. Now, the importance of detecting and managing postpartum depression from the role of an OBGYN, one of the things that is striking is that, the recent studies show that approximately 1/3 of all the physician visits for women of reproductive age are with their OBGYN physician. And many women report that their OB-GYN is their only source of primary care or routine health care. Women with symptoms of postpartum depression also identify OBGYN providers and their clinics as their preferred provider for mental health care. ACOG recommends that OBGYNs and other obstetric care providers should initiate screening, and they should screen patients at least once in pregnancy, and also to use a standardized, validated tool to identify those symptoms. Also, to complete a full assessment of mood and emotional well-being, including screening for postpartum depression and anxiety with a validated instrument during that comprehensive postpartum visit for each patient, which usually occurs between 4 and 12 weeks after delivery. OBGYNs should be prepared to initiate medical therapy, refer patients to appropriate behavioral health resources when indicated, or both. And it's important, obviously, that systems are in place to ensure that women are able to follow up for diagnosis and treatment. Now, one of the more common assessment tools is the Edinburgh Postnatal Depression Scale, or EPDS. And this is the most common tool that we see used for perinatal women. Now, it's a 10-item self-report. It's been validated in both pregnancy and postpartum. So don't get hung up with the title that it's only for postpartum use. This has been validated in pregnancy, and it's available in more than 50 languages. It considers both depressive and anxiety symptoms, which is really critical because they're often comorbid. It also focuses on mood-related symptoms rather than the somatic symptoms that can be present, such as lack of sleep or fatigue. A cutoff score of 12 has fairly good sensitivity and specificity, ranging from 80 to 90%. And the final item on question 10 assesses suicidal ideation or self-harm, and that should be given consideration independent of the total score. This EPDS has been found to be more accurate at identifying women with and without postpartum depression than the more common PHQ-9 or the postpartum depression screening scale. Now, a little bit more on this EPDS assessment tool. A recent review that included several randomized trials of more than 6,500 women found a lower prevalence of PPD at follow-up for those screened 4 to 8 weeks after delivery. And so if postpartum depression was diagnosed, improvement or remission of symptoms at follow-up was greater in patients who were screened than in those who were not screened. However, again, this is a screening assessment tool. It's not diagnostic. And so we know that women with elevated scores can also be suffering from bipolar disorder or certain anxiety disorders, and it may not be unipolar depression or postpartum depression. In fact, almost 1/4 of women who have an elevated score on the EPDS may actually have bipolar disorder. So that clinical distinction is really important. We're going to go into kind of how do you figure that out with just some self-report tools. And so we'll transition now to the toolkit for OBGYNs. This toolkit was created to really help clinicians with screening and diagnosis of postpartum depression, management of postpartum depression, and then overcoming treatment barriers through shared decision making. And so you can see in this toolkit that there's material from things we've covered already, but now really in a concise way allows you to have a lot of information at your fingertips very briefly. And so here we have for part 1, the screening and diagnosis, again, those risk factors, negative consequences, the diagnostic criteria, how to do that differentiation with baby blues and PPD. Here we have in our toolkit the EPDS. And so again, it's that self-report tool, again, validated in both pregnancy and the postpartum. The tools that are downloadable have all the instructions for the patient. We really recommend that the patient administers it to herself rather than a social worker or nurse asking the questions. And so women are somewhat more likely to answer honestly if they're able to write down the response. And you can do this with an iPad or some sort of tablet, or you can use paper. And so again, each item is scored 0 to 3. And the scoring here, there are a couple of questions that are reverse scored so that you want to be aware of that, because then the scoring changes. So again, that cutoff of 12 has fairly good sensitivities and specificities. And a positive score would lead us to doing additional interviewing. Obviously, we're also always paying attention to number 10, the thought of harming myself has occurred to me. And one clarifying thing on this question is that sometimes women misinterpret this question. Sometimes it's not intentionally harming myself, but accidentally harming myself. And so sometimes women will say, well, I have this anxiety in the winter, of falling on ice and falling on my belly, or when I'm going downstairs, I have this, these thoughts that, oh my gosh, what if I slipped and got hurt? That's not what we're asking about. So sometimes the simple question of, what were you thinking of when you checked off, yes, quite often, give me some examples. Just keeping it very open so that you can try to understand if it's really intentional self-harm or accidental self-harm. We've seen that quite a bit. And the next tool, again, focusing on that question 10. So here we really want to ask about, again, in the past 2 weeks, what are your thoughts? What have those thoughts been? So you can elicit in a very open way. Have you ever attempted to hurt yourself in the past? And have you thought about how you could harm yourself? So for any plans and any intent. And so we think of, the risk assessments as low, medium, and high. And, it's not just how she's responding on this questionnaire, but it's the context of the patient, right? And so if we have a woman who's reporting some fleeting thoughts that, I had these thoughts of just maybe it'd be better if I just didn't wake up, or I just want to escape. So those are low risk thoughts as long as they have no current plan or intent to harm themselves. But again, that's, in context that the patient herself is at low risk. So she doesn't have any history of suicide attempt or psychiatric hospitalizations in the past, and she doesn't have a history of bipolar disorder. So it's in that context that you have to kind of put the two together. And in this low risk case, then you really want to provide support, treatment options, arrange follow-up, and identify those resources and making sure that the woman connects with them. For more moderate risk, where there are suicidal thoughts there, so yes, I've had thoughts of wanting to die, and but I don't want to die, and I don't have any immediate plan, but I keep having the thoughts that I'd be better off dead, and maybe my family would be better off without me. Then it starts to get, especially if the frequency, we ask about, how often are the thoughts coming, and how hard are the thoughts to get out of your mind, right? So the more stubborn the thoughts are, that increases the risk. And again, this is a fluid, low, medium risk, sort of assessment. And so here, we really need to discuss treatment options, reassessing risk sooner than later, within the week or sooner, having a contingency and plan in case the patient develops a plan or means for suicide. And then for high risk, again, this really differs where, the patient's reporting, I want to die, and, after I leave this appointment, I may step in front of a bus, or I'm having thoughts that when in my car, I think I'm just going to drive into oncoming traffic, or I have a plan of overdosing on, my pills that I got from the hospital. And so here they're very specific, and they have the means available. And in those situations, the woman should not go home. And so they need to be escorted to the emergency room, whatever safety protocols you have in place for your practice. We know that a high percentage of women with bipolar disorder who stop their medication during pregnancy relapse very quickly after stopping the medications. And we know that women with bipolar disorder need to be treated differently than women with unipolar postpartum depression. Now, postpartum psychosis, which is often part of bipolar disorder, now this can be either with or without mania, is a psychiatric emergency and occurs in 1 to 2 out of 1,000 births. So again, for women with a history of bipolar disorder, this really raises the risk level and attention level that woman needs for mental health care. And we know that women with comorbid conditions are more likely to have self-harm ideation. And so one way to tease this out is that for every woman with a positive EPDS screen, to then administer a self-report tool called the Mood Disorder Questionnaire. This is also freely available and downloadable from the internet. It's a self-report, asks a series of questions if there's ever been a time in their life when they weren't their usual self and maybe experienced these symptoms. And the woman just checks off yes or no. And then really, I find I still have to ask, even though it does say, have several of these ever happened during the same period of time? And we're looking for distinct periods of time, right? So the irritability, the grandiosity, not needing to sleep, so feeling rested with like 2 or 3 hours of sleep, really having so much energy, when they speak, others can't interrupt them, very flighty behavior, not being able to focus on anything or complete things, or risky behaviors. When these coincide, like over the same week or a few days, and then go away, this is not, continued risky behavior or irritability, but rather punctuated periods of these behaviors that are all linked together. that is what we're looking for either a hypomanic or manic episode that would be part of bipolar disorder. And so, so that's a way of utilizing this tool. And again, so quick for women to fill out. It's less than a minute. And when it's all, all no's, you're much reassured that you're dealing with unipolar postpartum depression and can treat with standard of care, which we're going to go over. As I noted, many women can have anxious thoughts and anxious ruminations after delivery. And it sometimes can be confusing of whether those anxious thoughts are due to an anxiety disorder, or if they could potentially be due to more of a concerning condition of either psychosis or other severe mental illness. And so the intrusive thoughts that women can present with, again, to differentiate from depression, anxiety, or OCD, or a psychotic or homicidal condition, can be very distressing to women. These thoughts could be thoughts of harming their baby, thoughts of drowning the baby, thoughts of throwing the baby out the window, putting the baby in a microwave. They're incredibly distressing to women with anxiety. So here on the left, you'll see that women have good insight. They realize these thoughts are outside of their head and are very distressing to them, and they're taking precautions to keep that baby safe. They don't have psychotic symptoms. They don't have hallucinations or unusual beliefs. And again, they're very anxious. For those women, those symptoms are more due to anxiety, and the mom's not at risk of harming the baby. But alternatively, if a mom has similar thoughts but doesn't have good insight, or there's some part of her that would like to actually complete the thought or complete the act, then we think it's more psychotic and might be a delusional belief. And so for those women, that again is a psychiatric emergency, and they need to see psychiatric care immediately because the baby could be at risk. Now again, just as a review, for women with a positive screen, we want to dive a little bit deeper to figure out, is this a full depressive episode? Is it clinical depression or anxiety? Try to understand if they have a history or family history of psychiatric issues. It's always prudent to do some laboratory testing, especially to rule out postpartum thyroiditis, to administer the MDQ, to monitor for mania, also to ask about hallucinations or anxiety and some of the obsessive compulsive symptoms, which can be found in 10% postpartum women. And then obviously to do a risk assessment, and then to schedule, either the immediate or appropriate follow-up later for those symptoms and treatment. So when to refer to a perinatal health mental specialist? Whenever there are diagnostic concerns, or, the woman does screen positive on that MDQ, then I think really the woman should be very swiftly referred to mental health care to sort of figure out those diagnostic concerns, and also what the appropriate pharmacotherapy would be for bipolar disorder. But if there are multiple psychiatric comorbidities or addiction illnesses, or they've tried many treatments in the past and things haven't worked, or obviously any safety concerns, those would be key times to refer to a mental health specialist. And we know that this transfer of care works best if the OBGYN has a referral network in place, and so that the clinic or practice knows a group of either psychiatrists, psychologists, social workers, community supports that are at the ready and can work with the patient and their practice. Ideally, the specialist will have experience in working in perinatal women, and an important piece of this is that we just know that so many women that are handed a referral sheet and say, oh, we think you may have postpartum depression, please call these resources. so many of those women don't call out to specialists like us. And so to follow up with your patient to see if they did make the call, and then did they go to that first appointment? Are they engaging in psychiatric care is so important. And now it's your turn to practice using the toolkit to find information you need when screening a patient for postpartum depression. We're going to give you a question, and you will have to find the answer in the tool. So let's try it. You have to read the question, look at the tool, and go ahead and find the answer. And so let us begin now with Module 2, where we're going to explore current and emerging treatment options for postpartum depression. So for all women, including women with postpartum depression, we really do want to encourage self-care, sleep protection, exercise, psychosocial support strategies, and manage social stressors, medical conditions, any psychiatric comorbidities for women with postpartum depression. So for all women, no matter the severity. For those with more moderate symptoms of postpartum depression, we certainly want to start discussing psychological treatments. These are evidence-based treatments based on randomized clinical controlled trials for cognitive behavioral therapy and interpersonal therapy. And then also for moderate PPD, often antidepressants are indicated if there's insufficient response with psychotherapies. For severe postpartum depression, we often use both psychotherapy and pharmacotherapy together. We will need to sometimes consider switching the antidepressant or augmenting the antidepressant if the woman doesn't have a full remission of the depression with the single antidepressant. And then for women with severe PPD that's sometimes complicated with other symptoms such as catatonia or refusal to eat, severe weight loss, and other symptoms, then we consider ECT, electroconvulsive therapy, also for women who may need psychiatric hospitalization for suicidal ideation as well, or treatment resistance. And so there's a great evidence base for psychological therapies in postpartum depression. And again, women often prefer non-medication-based treatments for postpartum depression. These studies looked at, it was a meta-analysis of several studies for a variety of psychotherapies for postpartum depression, and showed that all of them had a positive effect size in reducing PPD symptomatology. And those effect sizes range from mild to moderate to very large effect sizes, and included studies with CBT, IPT, just general counseling, supportive counseling, and other psychological interventions. SSRIs, a type of antidepressant, have also been tested in randomized clinical controlled trials for the treatment of postpartum depression. And overall, a meta-analysis that was recently done showed that the effects of SSRIs are helpful for women with postpartum depression versus placebo. Regarding breastfeeding, antidepressants are not usually contraindicated during breastfeeding. And I think that this is an area for education for patients, because we often have so many patients who come in, well, I can't take an antidepressant, I'm going to breastfeed. And unfortunately, we find a lot of confusion with clinicians too in the field about the safety of many antidepressants in breastfeeding. And so we often, refer to the relative infant dose, and the RID percentage of less than 10 is often compatible with breastfeeding. So you can see here on this slide, many of our commonly used antidepressants in postpartum women are all less than 10. And so this indicates that small amounts of these antidepressants are found in breast milk, but are associated with low infant risk. And so we do want to have really good communication between psychiatry, OBGYN, and pediatrics to make sure that we're all on the same page and that women don't get conflicting advice from her different providers. There are some limitations though, right? For psychotherapy, we know that some women, it's just so hard to make the time commitment with everything going on. We find this even now with telehealth. It's still challenging for women to engage in psychotherapies. For some, it could be expensive with the co-pays or self-pay, and it takes time to work. For the antidepressants, the typical antidepressants do have, again, a slow treatment response, and so it does take time. And unfortunately, we just know that many women don't have full remission of their depressive symptoms. And sometimes they stop the medications before they can fully work because of side effects, and those are listed here. And then for ECT, we still find this underutilized in this patient population, often due to stigma. And again, this is for women with very severe postpartum depression. So fortunately, we're entering a new era in depression treatment, and it's beyond the category of antidepressants we've used in the past. And so for this patient population, I see an ideal antidepressant treatment as one with rapid onset and sustained response, something that's well tolerated and doesn't have side effects that are going to discourage women with sticking with the treatment. Something that's a short course or as needed rather than chronic therapy. Women have a lot of concerns about being quote unquote medicated for months and months and months or years. And so if we could develop something that is a short course of therapy, that is a huge advantage for patients. Obviously, if the mechanism of action can dovetail with the pathophysiology of PPD, that would be ideal. And also compatibility with breastfeeding, because we just know there's a barrier even with good education. And so fortunately in 2019, Broxanolone, which is a novel GABA-A receptor modulator, this became the first therapeutic to be approved for the treatment of postpartum depression. Now, it's very different than, it's the first in class, so it's not like other antidepressants that we can prescribe. It's a neuroactive steroid. And so neuroactive steroids are made from cholesterol or steroidal precursors. They're made endogenously, so they're made in the gonads, the adrenal glands, they're made in the placenta, and they're made in the brain. And these endogenous neuroactive steroids include allopregnanolone, and they're rapid and potent allosteric modulators of the GABA-A receptor. And so what does that mean? Well, we have decades of data, preclinical data for many years that have shown what a critical role these endogenous neuroactive steroids play in the stress response. And so they really regulate the HPA axis during non-stress, acute, and chronic stress situations. And depressive disorders, including postpartum depression, are stress-related disorders. Now, Broxanolone is synthetic allopregnanolone, so they're biochemically identical. And that is the medication that was FDA approved for PPD. Zuranolone is an investigational neuroactive steroid, so that is not FDA approved. That is under investigation. It's an oral neuroactive steroid, really chemically similar to allopregnanolone, but not identical. And again, that's being examined in ongoing clinical trials for the treatment of major depressive disorder, so non-puerperal depression and postpartum depression. And so we know from preclinical and clinical work research that allopregnanolone has a role in the pathophysiology of postpartum depression. So we know that across pregnancy that the high levels of sex steroids and neurosteroids, including allopregnanolone and estradiol, they really shape the maternal brain. And so they shape the brain for motherhood and in response to these high levels of estrogen and progesterone that are going to sustain the pregnancy. And then after delivery, those hormones drop precipitously and the brain again changes, not exactly to pre-pregnancy level, but it changes again as those hormones are withdrawn. And so we know that the communication between these neuroactive steroids and the GABA-A receptors is critical in this adaptation to the hormones of pregnancy and the withdrawal of them after delivery. And the evidence of research is showing that there's an inability, perhaps, of the GABA-A receptors and the neurosteroids to adapt to these changes, triggering changes in the brain circuit, which we see as symptoms of depression. So Broxanolone, again, the first approved and first in class, so it's completely different than any of the other antidepressants, was approved for PPD in the United States. It is administered as a continuous IV infusion over 60 hours. So it's just a peripheral IV, and it's in supervised, usually inpatient or infusion center settings. Women can continue if they're on a stable antidepressant that they've not gotten complete relief from, or if you wish to start an antidepressant, that can be started after the infusion as well. There is monitoring that is required with the administration of the medication. A healthcare provider has to be on site to monitor the patient. They have to be monitored for potential hypoxia using continuous pulse ox, and be examined for sedation every 2 hours during the non-sleep periods. And then we usually start the infusions early so that you can identify any excessive sedation during the daytime hours rather than being during the sleep or bedtime hours. And if excessive sedation does occur, just turn the infusion off, let the symptoms resolve. Most women just start to feel sleepy and then will wake up again. And so then at that point you can either resume it at the same dose or you can try a lower dose as well. This medication, Broxanolone, is only available through a restricted program of the FDA called a REMS program. And there are many medications of many different classes that are utilizing a REMS protocol. We know from the clinical studies that the efficacy showed a drastic reduction in depressive symptoms in 2.5 days, and so during that 60-hour infusion. Now, given the risk of excessive sedation or sudden loss of consciousness, especially if there's any pump malfunction, so that's why monitoring is very critical. That's why this medication carries a black box warning. And then other adverse reactions can include dry mouth and flushing. And so, these trials, which we had published just a couple years back, were really based on studies done in women with moderate severe postpartum depression that started either in third trimester, the first 4 weeks after delivery. They were randomized to placebo or 2 different doses of IV Broxanolone. Then we shut the pump off at 60 hours. We evaluated them. They were followed up at day 7 and day 30. And as you can see here on this figure, you see a precipitous drop in depression scores. So these are the change from baseline. And you can see that, again, at hour 60, the pump is off, yet women stayed well all the way throughout day 30, which is their last day of the study. And then also 2 things that we look for in depression trials are response. So the number of women or percentage that are 50% or more better based on that depression scale, or remission, meaning there's no longer clinical depression present. And so you can see at the 60-hour point, 75% of women with Broxanolone met that criteria for response versus 56% with placebo. And again, at that 60-hour, 50% no longer had clinical depression at that time point, at the hour 60, versus the 26% in placebo. And so these rates are, we don't have a head-to-head comparison study looking at Broxanolone versus a standard of care antidepressant, but if you were to take the meta-analyses of them, these are working better than the standard of care, and they're working faster. For adverse reactions, those are listed here. Again, it is a GABAergic medication, and so we do expect this medication, similar to other GABAergic medications, to have a profile of sedation or somnolence, vertigo, pre-syncope dizziness. Those are kind of characteristic of medications that go through the GABA receptor, even though neuroactive steroids use a very different GABA receptor than other GABAergic medications like benzodiazepines and other drugs. But you also see some dry mouth and diarrhea and some flushing as well. So, so I love this article because it really gives some clinical pearls of, who would you refer and who's kind of a good patient for Broxanolone. So really, women who have had an onset as early as 20 weeks gestation to 5 weeks postpartum could be considered for Broxanolone if insurance will cover. And then, you can still consider patients who are still depressed after 6 months postpartum. Really, the studies have only been done in moderate to severe depression. So, those EPDSs should be in the more moderate severe range. In the 20s would certainly be someone who might be eligible. And then, if a woman also has a comorbid anxiety disorder, the studies were done in women with comorbid anxiety disorders, so that would be fine as well. There's no reason to exclude those women. However, women with bipolar disorder, psychotic illnesses, current substance use disorders, or active suicidal ideation with plan and intent would not be best candidates for the medication. They're ineligible for this treatment. Many women do benefit from continued treatment with an oral antidepressant. That it's not just, okay, receive the infusion and, discharge the patient without follow-up. Outpatient care is really important to make sure that, if the woman wants to engage in psychotherapies or community supports, there are other aspects of care that can provide a more holistic approach. And then we do tend to reduce the doses of GABAergic medications by half, just to be on safety side so that there's no additive effect of potential sedation. And then for prior authorization, there are some key features listed here that are important, including the diagnosis, the date of delivery, the documentation of the severity, usually with a validated tool. And then if breastfeeding, most insurers want documentation that the patient will pump and dump just during the infusion period and 4 days after. And regarding that breastfeeding, the RID in breast milk 36 hours after infusion is 1% to 2%, so it's quite low. And oral bioavailability of Broxanolone and allopregnanolone is also low. Now, again, we discussed the black box warning. That's for sedation and potential sudden loss of consciousness, and the requirement for continuous pulse oximetry, and the patients are accompanied during interactions with their children, and that the medication is only available through a REMS program. Now, there are many ways to become certified to dispense Broxanolone, and to have the ability to monitor patients, to train the staff on prescribing, dispensing, establishing the procedures for dispensing and administering Broxanolone, and also to adhere to some of the forms and programs that are required within the REMS. So this slide outlines those requirements for REMS, and to gain access to the program or to become REMS certified at your institution or practice, all of the materials that are needed are on the Zulresso REMS website and are all downloadable. So you can enroll in the training program, the slide decks there, all of the papers and the forms, all the information is readily available from that site. Now, I did note earlier that Zuranolone was an oral neuroactive steroid. It is biochemically different than allopregnanolone, and for a good reason. It's orally bioavailable, where allopregnanolone has poor oral bioavailability. And so Zuranolone, we completed this study and recently published it, and this was done in severe postpartum depression. Women were randomized either to placebo or a 14-day oral course. So they took the capsules at night for 14 nights, and we evaluated them at day 15 and 45. We see a really similar response curve for the depressive symptoms, with very rapid reduction of depressive symptoms with statistically significant and clinically impactful differences at day 15. You can also see that women stayed well all the way through day 45, but remember, they only took the oral zuranolone from days 1 through 14. And here you can see we always measure response and remission of depression, because those are really clinically important variables of interest and clinically impactful for the patient, that we know that symptoms are at least 50% better, or if they're clinically remitted and don't meet criteria for major depression any longer. And so you can see that treatment with zuranolone 30 milligram resulted in greater percentages of patients meeting response or remission compared to placebo across the study. And also, I mentioned that anxiety is quite comorbid in PPD. Anxiety also responded. We had sustained improvements in anxiety symptoms as measured by this anxiety tool. And those were seen across the study and follow-up periods. And again, you see a similar curve where the symptoms are that resolution or reduction of symptoms are stable across time. Now, for treatment emergent adverse events, zuranolone was well tolerated. The most common treatment emergent AEs were somnolence, headache, dizziness, upper respiratory tract infection, diarrhea, and sedation. And in the placebo group, some of the similar ones were there. And you can kind of compare and contrast the percentages to see if they were nearly similar to placebo or if they were elevated compared to placebo. Most of these TEAEs were mild or moderate. And currently, there's a phase 3 clinical trial called Skylark. This is testing a different dose of zuranolone. It's higher. So the Robin study, which I just presented, was tested at a 30 milligram dose. This is now testing it at a 50 milligram dose. And this is also a randomized double-blind phase trial. Again, this is outpatient, so it's an oral treatment for 14 days. And so the results of these are pending at this time. So let's head again to our practice aid. Here, are our evidence-based treatment recommendations. Again, for all women with postpartum depression, it's important to emphasize self-care, sleep protection, exercise, psychosocial supports, and really connect women with community resources. So peer support groups, seminars or educational opportunities, places for women to connect with other moms are really important for all women, because it really does help to manage and mitigate social stressors that they're under. Obviously addressing, any comorbid medical conditions during this time as well. For more moderate or severe postpartum depression, so again, when the EPDS is not just simply a 12, but it's more of a 16 or 18. Now you're getting into more moderate symptomatology. This is certainly functioning impairing, and connecting that patient with psychological interventions, and hopefully evidence-based CBT or interpersonal therapy, IPT. Those have the highest level of evidence based on RCTs of higher efficacy than supportive counseling. But also making available antidepressant treatments, whether that is an SSRI or Broxanolone. Those are the main two categories of antidepressants available. There's also SNRIs, and for women with more treatment resistance, tricyclics, but typically they'd be under the care of a psychiatrist. And then for severe postpartum depression, again, combining these is most often. There are some women who will just have monotherapy with an antidepressant, be it a standard of care antidepressant, a traditional antidepressant, or Broxanolone. But ideally, we find the best responses when both are using, because they're working differently on the brain and on the brain circuit. And then for very severe or treatment-resistant postpartum depression, ECT is an important consideration. And so also part of this module 2 practice aid includes some of those slides that will, again, bring all that data into a concise way for discussing the basics about Broxanolone, and then some of the clinical pearls about patient selection, which I think is really helpful. Also, if you're interested in becoming a site for Broxanolone therapy, those are outlined here, some of the requirements, but then also the practical, how do I get this up and running, and how do I get this started and make this treatment available for my patients? So those are outlined on this slide as well. And again, that website contains all the resources that are needed to become a REMS certified site for Broxanolone therapy. Now it's your turn to practice using the toolkit to figure out which treatment option you should discuss with your patient. So we're going to give you a question, and you will use the tool to find that answer. And let's conclude with Module 3. So let's incorporate shared decision-making into the management of postpartum depression to empower our patients and to optimize their clinical care. Again, we know that postpartum depression often goes undiagnosed, untreated, or undertreated. And so, unfortunately, we know that women may hide their symptoms from their clinician. And I know that women have come to me and I'll say, but your EPDS was 0 2 weeks ago. Tell me what happened. And she's like, oh yeah, I lied on that. I didn't want to say anything. And so we know that sometimes we don't get moms who feel comfortable discussing their symptoms with their providers. And here this study looked at and said almost 21% of new mothers who were experiencing postpartum mood disorders such as anxiety and depression did not disclose their symptom to healthcare providers. And even when we identify PPD, it doesn't guarantee that women are treated for it. So we know that between 34 and 60% of women who report significant symptoms of postpartum depression to the provider never engage in care. Remember I mentioned back, I know this in our center, we have a really close connection with our OBGYNs, and they say, oh, we refer everyone over, and I'm like, where are they? Like, they never called, they never asked for an appointment, or they made an appointment, they didn't show. So it just underscores the need for improved communication between ourselves as healthcare providers and our patients to ensure that women with PPD really do receive adequate diagnosis and treatment. There's so many barriers for women to seek treatment for postpartum depression. So, it's a complex issue of whether they want to seek treatment or not. And they're trying to weigh the perceived need for treatment against the risks and their perceived risks of treatment, the effects of their treatment choice on their child, especially including breastfeeding. We just see so much misinformation and lack of education in this area. We also, find that there are additional barriers. So obviously accessibility to care, the cost of care, time constraints, fear of losing their child to child protective services is a real fear. Lack of motivation, lack of support. These are all impacting women and their ability to get the care they need. And so shared decision-making is a process by which, we as clinicians and patients engage in a dialogue around the available treatment options, and especially when there are multiple options to choose from. And so we want the education to include information about PPD, available options, risk and benefits to each option, as well as, no treatment at all. So, how does the risk of an antidepressant compare with what if you didn't seek any treatment at all and the depression remained, and how is that impairing the woman and her child and her family? And so it's important to do that risk-benefit alternative analysis so that women have informed consent about their treatment options. We want to assume that individuals want to be active participants in their care, and that we want to encourage deliberation around these options and promote the sharing of information. The shared decision making improves their overall understanding of what options there are, and they can have confident treatment choices that align with their needs and their values. And studies find that women who are experiencing postpartum depression symptoms prefer an active or collaborative role when exploring mental health treatment options. Now, we're going to discuss this a little bit more detail in our practice aid for this module, but I do want to highlight some of the things that we're going to go into detail. So we'll start with seeking your patient's participation, and then we'll proceed to helping your patient explore and compare treatment options. Then we're going to learn to use effective and listening skills to help your patient assess their values and preferences, and then reach a decision with your patient. Finally, evaluate your patient's decision. So let's head back to our practice tool to take a deeper dive into some of these issues of shared decision making. So the first step in the shared decision-making process is to seek your patient's participation. And so you see in the first bar on top, too often treatment decisions are made for patients and without regard for their values, preferences, or goals. We want to communicate that a choice exists and invite our patients to participate in the process. It's important to summarize the health problem and let our patients know that there are options to consider. Understanding and describing it clearly to patients and openly allows our patients to understand that a decision needs to be made. And then asking our patients to participate with the healthcare team in making that treatment decision, helping her understand that she's being invited to participate and ask questions and discuss options with you, and let her know that her participation is important and valued. Asking if your patient would like to have family members or caregivers participate in the discussion is also important. Now, in this lower bar, you can see some of these conversation starters. You can take a look at some of those. And as we go through the different steps, you'll see these conversation starters on the lower bar for each of these steps in shared decision making. Because then we're going to want to help our patient explore and compare treatment options next. And here, again, no single option is clearly superior. We want to use evidence-based decision-making processes and resources to help patients compare the treatment options. We want to assess what the patient already knows and where there are gaps in their understanding. Let's write down a list of options and describe them in plain language. We could point out where there's clear differences in the treatment options, perhaps between psychotherapy and an antidepressant. And clearly communicate the risks and benefits of each of those, of what's known and unknown about the options, and what would happen with no treatment. That's a really important one that often gets forgotten. Then communicate numbers with visual aids, graph charts, something that's really tangible to the patient, and summarize by listing the options again. And then the use of teach-back techniques can be very valuable to check for patient understanding. So again, you'll see some of these conversation starters here that'll help you explore these pros and cons of treatments. And then the next step will be to use effective communication and listening skills to help the patients assess their values and preferences. So here, again, we want the patient to talk about what matters most to her. Ask open-ended questions. Listen actively to your patient, using prompts to continue talking. Go on, tell me more. And also, obviously showing empathy and interest in the effect that a problem's having on your patient's life, and validating her feelings, acknowledging the values and preference that matter to her, and then agree on what's important to your patient. So here, again, are some conversation starters for this piece of the shared decision-making process. Next is to reach a decision with your patient. So help your patient move towards that decision. Ask if she's ready to make a decision, or if there are additional questions. Asking if more education via different tools or materials or decision aids would be helpful, and checking if they need more time to consider. confirming the decision with the patient when she's ready, and then verifying sort of what the next steps are to go forward with that decision, and then always following up. Here are some in blue, these conversation starters for step 4. And then evaluating that decision in step 5. Once that decision's been made, then it's important to follow up with the patient to see how she's doing. Remind that, treatments can be changed. You can change, as you're going on this course, as you find out what is working well and what's not working well for your patient. And monitor, to the extent of which treatment decision is implemented to make sure it's in place, because sometimes the treatment just does get lost in the shuffle. Revisit the decision with your patient to determine if other decisions need to be made. And so here you can find some conversation starters for prompting future evaluation. So now it's your turn to practice using this toolkit to review how shared decision-making can help clinicians and patients engage in dialogue around available treatment options for postpartum depression. So we're going to give you a question, and you'll use the tool to find the answer. Thank you again so much for joining us today. I truly hope it helps you help care for women in your practice who may be suffering from postpartum depression.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/HYR860. This activity is supported by an educational grant from Sage Therapeutics and Biogen. This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer View Institute for Medical Education.